Okay, hello everybody. I am Eileen Callahan and I'm here with Christine Chang. We are two geriatric attending doctors from the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. And we will spend the next 45 minutes talking to you all about urinary incontinence. We have no disclosures to speak of. The objectives for this session will be that after the session, you will all be able to evaluate most patients with urinary incontinence symptoms, be able to diagnose what kind of urinary incontinence your patient has. You'll be able to manage these disorders with and without medications. And then lastly, recognize when it's time to refer your patient to one of your specialist colleagues. A little bit of background. In women, mostly the studies have been really shown in women. The prevalence studies were demonstrated that about 38% of patients over the age of 60 years old living in the community suffer from some form of urinary incontinence. And as you see, that number skyrockets. Close to 80% of nursing home residents in the US now suffer from some degree of urinary incontinence. The cost to our country and society is staggering. In 2000, the data showed that about $20 billion were spent both in the community and in the nursing home for patients that are suffering from urinary incontinence. And as you can imagine, the burden is enormous. Our patients and their caregivers suffer from incontinence. It creates a very large burden on those patients and their caregivers. Some recent studies were suggesting that it actually can increase a person's risk of falling. And as you can imagine, if you've seen patients yourself who have this problem, they either race to the bathroom and they may fall on the way, or if they have leakage, they may slip on the urine on the floor. And there's new guidelines emphasize that all women should be screened for incontinence. Okay, so we want to emphasize that age alone does not cause urine incontinence. But like every other organ system in your body, there are age-related changes that do occur. And these changes will predispose an older person to developing urine incontinence. And let's go over these. So as one gets older, the bladder capacity decreases. What that means is the bladder does not allow the same amount of urine to be stored at an older age that it did at a younger age. The second change is the bladder contractility does decrease. So what that means is when it comes time for a normal void, the bladder, that's the muscle, does not contract as strong as it did when one was younger. These will lead to a small increase in the bladder residual volume. That is, after a normal void, an older person can get a little bit more residual volume just with normal aging alone. Longitudinal urodynamic studies have shown that there are involuntary contractions that are common with older bladders. This should not necessarily be clinically relevant, but as you can see with some of these other changes, it will predispose someone to developing urine incontinence. One of the biggest complaints we all see as geriatricians is urine excretion at night increases. Nocturia increases in older persons separate from any pathologic state, just from normal aging alone, probably related to anti-diuretic hormone factors. In women, after menopause, estrogen level decreases as a female gets older, and then in the males, the prostate does enlarge. So again, all of these age-related changes will predispose an older person to developing urine incontinence. And like everything else in geriatric medicine, everything is often multifactorial in cause. So you have these age-related changes that I just described. They may develop some urologic problem, just a simple urinary tract infection, maybe bladder stones, something that happens as you get older, and they develop comorbidities such as arthritis, spinal stenosis, their gait may be abnormal, they can't get to the toilet when they need to, and then the environmental obstacles that we all know of when we see our patients in the hospital. They cannot get to the toilet on time because they're tethered with IV poles and monitors. So all of these problems combine to cause somebody to develop urine incontinence. Okay, I'm going to spend a minute going through this complicated looking diagram, but it really does summarize the very intricate and complex balance in how one maintains normal urination. And it really is focused on the brain, the bladder, and the urethral sphincter, with a lot of pathways in between. So if you can just remember that the bladder is under really strong parasympathetic control and the urethral sphincter is under sympathetic control. So to maintain continence, there's a switching back and forth between a filling, storing stage of urine and then the voiding stage. So if you want to think about as the bladder is relaxed and it's allowing the urine to fill it up and store, that is under sympathetic control. The parasympathetic system is being inhibited, and that allows this bladder muscle to be relaxed because the bladder muscle wall is very rich with muscarinic receptors. While that's happening, again, the filling, storing stage, that sympathetic system is being activated, and that causes constriction and closure of this external urethral sphincter. Okay, that is the filling, storing stage. Then signals are being sent up to the brain through the pontine micturition center, and it says, okay, the bladder is filled now. And that varies in different people, anywhere from 4 up to 600, even more cc's of urine in one's bladder. It tells the brain, now it's time to void. This is normal voiding. The brain will now send signals down and it flips. So the parasympathetic system is being activated. So these receptors are being stimulated, causing this bladder muscle to contract. While that's happening, ideally, the sympathetic system is inhibited. And what that means then is this external urethral sphincter relaxes and opens up. So again, during the voiding stage, the parasympathetic system is activated and the sympathetic system is inhibited, and that allows normal voiding. So again, normal urination is a very complex interplay between the parasympathetic and the sympathetic system to go back and forth between the filling and storage stage and then the voiding stage. This is going to be very important to remember this concept when we talk later about medications that can cause incontinence and medications to treat incontinence. Okay, so we would be remiss if we did not put a slide in about the mnemonic of causes of acute incontinence. And Neil Resnick developed this a long time ago, and it still holds true. And this is important to remember if you get called an urgent complaint about a person who has new incontinence or worsened incontinence, right? We all have those patients that maybe they have a little bit and now all of a sudden a lot of incontinence. So in your mind, in your evaluation, you should be ruling out all of these causes. And the mnemonic is diapers with 2 P's. So if somebody has delirium, they are at a higher risk of developing acute incontinence. If they have infection, right, that is something that can cause an acute infection in an older person, both men and female. The atrophic vaginitis and urethritis, I think we all forget about this. I think where it is very underdiagnosed and undertreated, women that develop atrophic vaginitis and urethritis, and they present very often atypically with symptoms of a urinary tract infection or incontinence symptoms. The first P is psychologic. That really speaks to that person that is very depressed, apathetic, and they may not want to put the effort in to go to the toilet for a normal void. The second P is pharmacologic. We have a lot of slides on this later on to go over some of this in more detail. These are just some examples of the diuretics, anticholinergic, opioids, but we will talk more later. E is excess output. Don't forget about this as a cause of incontinence. If you have somebody that's fluid overloaded from congestive heart failure, and you're causing them to diurese, combine that with the age-related changes, they will develop urine incontinence. Diabetes, that is not well controlled, or hypercalcemia that is not necessarily diagnosed, that can cause an osmotic diuresis and cause somebody to develop incontinence. The lower extremity edema, I think, is important to think about with somebody that has chronic venous insufficiency in particular. So we see this all the time, and this is important to emphasize to the patient that this can be managed and possibly decrease their nocturia or decrease their urinary incontinence episodes if they manage their lower extremity edema. The R is restricted mobility. That is those patients that are in the hospital that are tethered to the bed, or they just don't have a clear path to their toilet. The S is the stool impaction. That is if somebody does not complain of constipation, or they do, and they develop stool impaction, that can cause actually a physical outflow obstruction to the urine output. So remember to evaluate for all of these etiologies, because it could potentially be reversible. And like I said earlier, very often this is multifactorial. Okay.
All right. Thank you, Dr. Callahan, for reviewing the background, physiology, and the acute reversible causes of urinary incontinence. So now let's take a step back and use the case of Mrs. Henderson to highlight key features about the evaluation of urinary incontinence. We'll go over the important history, physical exam findings, and diagnostic testings that you can do in the office to make the diagnosis. So here we are, we have Mrs. Henderson who's in front of you. She's a 76-year-old female here to establish primary care. She has no acute medical concerns. Her past medical history is notable for hypertension and knee osteoarthritis. Her medications include hydrochlorothiazide, amlodipine, calcium, multivite, and ibuprofen as needed for her knee pain. Her physical exam is notable for normal vital signs. Her HENT is within normal limits. Her lungs are clear. Her cardiac exam is regular. She is noted to have some trace bipedal edema, as well as venous stasis changes and prolific osteoarthritic changes to the knees. Her gait is slow and unsteady due to pain in the knees, and you notice an incontinence pad in her undergarment. So for the evaluation of urinary incontinence, it's really important to remember that many patients do not report urinary incontinence symptoms because it's maybe embarrassing or a stigma. And there's often they feel that there's nothing that can be done, as they think it is a part of normal aging. So the first thing to do for the evaluation is ask the patient if they have incontinence symptoms. And then the type of urinary incontinence can be determined based on the history, the physical, and other testing. So here are some common questions that you can ask your patient in front of you, explore their past medical, past surgical histories. You do want to review their medication list, especially for high-risk meds, which I'll go over in the next slide. And then also review any other prior treatments that have been tried in the past to manage the urinary incontinence. Also, doing an environmental evaluation is important to make sure that the patient has access and clear, safe paths to the toilet. Doing avoiding diarrhea can be super helpful as well, and I'll go over an example. As you know, the history is often more useful than even the physical exam. Okay. So now a word about medications that affect continence. So remember the picture of the anatomy with the cholinergic and sympathetic receptors that Dr. Callahan had just mentioned? If you have a medication that affects any of these receptors, you can affect your continence. So it makes sense that cholinesterase inhibitors, antimuscarinic, anticholinergic agents, alpha adrenergic alpha agonists and blockers can contribute to incontinence. Just highlighting the antimuscarinics are quite common, such as antipsychotics, antidepressants, anti-Parkinsonian medications, and don't forget your inhalers, the anticholinergic inhalers for COPD. Other medications that affect continence include diuretics, sedative hypnotics, and opioids. And as you recall, they contribute to the commonly acute reversible causes of incontinence with excess output with the diuretics and any medications that cause delirium, restricted mobility, or stool impaction, as with the latter medications, can contribute to incontinence. Here's a sample voiding diary. I like this one because it's put out by the NIH. It's free, it's comprehensive, and it's easy to use. What's helpful is that it allows you to clarify the time when there's an input, so something that you drink and how much. It also records outputs, so trips to the bathroom, so how many times and how much. If there's any accidental leakage during that time and you want to quantify small, medium, and large, and if it's associated with a strong urge to go, and other activities such as sneezing, lifting, sleeping, etc. So this is a bladder diary, and here are the results for Miss Henderson. She has frequency every 1 to 3 hours of small volume. Her capacity is about 300 cc's. She has 2 to 3 accidents a day, and her urgency is triggered by water or bowel movement. So once urinary incontinence is diagnosed, there are some simple questions that can be used to help determine the type of incontinence that's involved, whether it be urge, stress, mixed, or overflow. As you know, these historical questions are really important because most people can be diagnosed without referrals or invasive testing. So here are 2 questions that have been verified and vetted by systematic reviews to help diagnose the type of incontinence. The first question is, do you experience such a strong and sudden urge to void that you leak before reaching the toilet? And if they answer yes, the positive likelihood ratio that they have urge incontinence is 4.2. And if they say no, the likelihood ratio is 0.48. The second question is if you have leakage with stress maneuvers. So if they say yes, the positive likelihood ratio is 2.2. And if no, the likelihood ratio is 0.39. Now, if you combine these 2 questions and quantify its frequency, you can come up with a screening tool like this. And here, if you ask, do you have any incontinence, even a small amount? If you say yes, you go on to question 2. During the last 3 months, did you leak? And so you check all that apply. So here are the 3 questions. When you were performing some physical activities such as coughing, sneezing, or lifting or exercise, or when you had an urge or the feeling that you needed to empty your bladder but could not get to the toilet fast enough, or without physical activity and without a sense of urgency. So you click all that applies. And then for the question 3, did you leak urine most often? So you only check 1. So it's those same 3 questions plus D, about equally as often with physical activity as with a sense of urgency. So the definition of the type of urinary incontinence are based on responses to this third question. So if most of it is with physical activity, then likely they have a stress only or stress predominant incontinence. If it's most often with urge to empty the bladder, the type of continence involved is likely urge only or urge predominant. If it's predominantly without physical activity or a sense of urgency, it's probably one of the other cause only. And then if it's equally with both physical activity and a sense of urgency, then you have a mixed incontinence. So here are the answers for Miss Henderson. Her voiding diary reveals she has an urge to urinate and she leaks on the way to the bathroom. It's not related to any particular activity. She voids 8 times in the daytime and 3 times at night, and sometimes she arises wet in the morning. Now, after your history questions, a focused physical exam will help determine the type of urinary incontinence and how to approach the treatment options. So here are the 6 domains that you can include: mental status, gait evaluation, fluid status, GI, GU, and rectal exam. So for mental status, it's really important to assess their cognition and mood, to evaluate how motivated and cognitively intact they are in order to figure out how able they are to participate in the various non-pharmacologic interventions related to bladder training. It's important to assess the gait to see if they are steady or if they need to use an assistive device to help get to the bathroom in a timely manner. Fluid status, looking at the lower extremity to see if there's any excessive edema, which will contribute to nocturia. The GI exam is important to pay attention to any distended bladder or suprapubic tenderness, which will be important in diagnosing a reversible cause of incontinence. For the GU or GYN exam, it would be important to look in the area, look for any vaginal atrophy, or if there's any evidence of prolapse. So it's maybe amenable to other treatments, including pessaries and topical estrogens. And then finally, the rectal exam is key to look for stool impaction. And looking at the sphincter tone will be helpful to assessing the neurologic function of the S2 through 4. Now, after the history and physical, are some simple office testings that is recommended, and I have a couple of the references down here. There are 3 key things to consider: urinary stress testing, post-void residual, and laboratory testing. So let's first talk about the urinary stress testing that can be done to replicate incontinence, whether it be in the standing or lithotomy position. A positive test has a positive predictive value of 78 to 97% for stress incontinence. Post-void residual is super helpful to see if there's any obstruction. Nowadays, you don't have to do a physical in-out catheter. You can use one of the bladder scans to measure the actual post-void. So post-void residuals less than 50 is considered normal, and those above 200 is considered abnormal. Finally, laboratory testing. Most often, providers, it is recommended to collect a urinalysis and a culture to rule out infection and to look for blood as well as crystals. In addition, serologic workup may be helpful, looking at the BUN creatinine, calcium for hypercalciuria, glucose to look for hyperglycemia, which all can be contributing to your acute reversible incontinence.
So thank you, Dr. Chang. So I have several slides here that all talk about the guidelines for evaluating somebody with urinary incontinence. I'm not going to spend much time on it, but I think it's important to drive home the point that many agencies across the globe now are coming up with updated guidelines on how to evaluate somebody with urinary incontinence. And as you can see here, it talks about the European Association of Urology, the International Consultation of Incontinence, ACOG, American Urogynecologic Society, the NICE group, and other urologic organizations all now have updated guidelines on how to evaluate a person with incontinence. They're all very similar. I'm going to hash these out a little bit more in detail, but there's a lot of overlap in terms of what Dr. Chang was saying, and really focused on the history of the incontinence, the bowel history, the physical exam that she mentioned, and then the bladder and voiding diarrhea. And there's a lot of overlap with these organizations. She also mentioned that doing a urinalysis, the PVR, and also it is important to remember that most of these are saying that routine imaging is not recommended, and most patients do not need evaluation with cystography. So most of these patients can be evaluated by the internist. They don't need the specialist. So shifting gears a little bit to the principles of treating these patients, like anything else with our patients, you want to establish what are the goals for treatment for that patient that you have in front of you. It really is going to be determined based on their cognition and function and motivation, just like Dr. Chang had mentioned. Then, after you establish what the treatment goals are, you want to focus on what specific symptoms they want to decrease. Are they incontinent episodes? Are they the number of times they have to go to the restroom if they're out and about during their day and this is a bothersome symptom to them? Do they have bothersome urge symptoms, or are they up 8 times a night to urinate? So really sit down and figure out what is most important to that patient in front of you. Or is it somebody that's very functional and active and they want to increase their social activities? They've been dying to go on a cruise and they can't go on the cruise because they don't want to take their pads with them. They're embarrassed. Or is it somebody that has advanced dementia and they're living with the daughter, and the caregiver is beside herself now because the patient has wet the sheets and the towels and the blankets and the floor. So now this is a goal, would maybe be to try to keep that patient in their residence. So once you've established what the treatment goals are, think about a step up approach. And I think about this as similar to the step up approach to pain management. You're always going to begin with the least invasive treatments and then go forth after that. So the starting off with behavioral therapies, adding medications if need be, and then certain procedures. And we will go over all of that. Throughout all of this, remember lifestyle changes. Weight loss is very, very, very helpful. If somebody is obese, that can really help decrease their stress incontinence in particular. Limit caffeine and alcohol if that is something that you notice in their voiding diary. Also, don't forget about advising them on controlling the timing of fluid intake. Lots of patients out there will start drinking a lot of water before they go to bed. So counsel the patient on that. And also, it's very important to counsel patients that are smoking to stop smoking because that is a bladder irritant. Okay, just a brief overview on the American College of Physicians. This is a decade old now, but they recommended way back then about the similar therapies that I will go into in more detail: pelvic floor muscle training, bladder training, and then medication. So I will go over that. And the same agencies also recommended the similar approach: behavioral therapies, all of this lifestyle therapy, such as caffeine, weight loss, treating constipation, and pelvic floor muscle training. So I will go over each of these in detail. So we alluded several times to the behavioral therapies, behavioral treatment for urge incontinence. So what does this mean? It really will depend on the patient's motivation, cognition, and how you're going to approach that. If somebody is very motivated, cognitively intact, and does not want to add another pill to their regimen, you're going to counsel them on this bladder training. This is number one. Terminologies that have been thrown out there are freeze and squeeze, mind over a bladder. There's a lot of different ways to think about this. Basically, you're going to work with your patient, and you're going to tell them that think about that abnormal urge they have in the middle of the day. You want them to think about delaying that void sensation. You're going to have them suppress that urge sensation, and then doing that, you'll be practicing distraction and relaxation. What does that mean? You're ideally going to tell them once you get that urge to urinate and you just had a normal void, say an hour ago, based on your avoiding diary, you're going to say, okay, distract yourself, go on the computer, talk to somebody, maybe listen to music. You're going to distract yourself to let that abnormal urge sensation resolve, and you're suppressing that urge. And then over time, ideally, you will gradually increase the time between voids. It is so important to emphasize to the patient this will not work in a day, it will not work in a week. You have got to set expectations and explain to them that it might take 4 to 6 weeks, but there's plenty of data to support that this is very effective. That is the first tier of behavioral treatment. The second tier is this concept of prompted voiding. This is working now with the caregiver, with the patient. You're doing the same counseling on bladder training, but now you're recruiting the caregiver with them. This might be somebody that has a little memory problems. So you're going to tell the caregiver to do the same thing and working with the patient. And then the caregiver will encourage that patient to void at a set time. The third tier I consider is this scheduled toileting concept. I think most people understand what that means. This is for somebody that has more cognitive impairment, not as motivated. You're really working with the caregiver on saying, okay, just schedule the toilet every 2 to 3 hours while the patient's awake. Over time, actually, though, this will work on its own, train the bladder, and decrease the episodes of incontinence. I think explaining to the patient that this can take weeks is the most important thing also. So if all of that fails, let's talk about medications that might be needed. The mainstay for years has been the anticholinergic medications. But as you probably are aware, most patients stop it after a year. Studies have shown that less than a third of patients remain on the medications in a year. In general, the extended release formulations have a better side effect profile. In general, the efficacy between the extended release formulations are all the same. They all have the same side effects of dry mouth, constipation, and urinary retention. There's some recent data to suggest that long-term use of these medications may have some cognitive impairment side effects. Here are a list of anticholinergic drugs for your reference. I won't go over them for the sake of time, but this is also an important advancement in the therapies for urge incontinence, are these beta-3 adrenergic receptor agonists. Remember what I said about the slide earlier with the anatomy. The bladder wall has mostly muscarinic receptors, but there are some beta-3 adrenergic agonist receptors on the bladder wall. And these agonists have been developed to help minimize urge incontinence. The two that are on the market are Mirbetriq and Mirbegron and Debegron. When these receptors are activated, it does promote smooth muscle relaxation and decreases the frequency of bladder contractions during that filling phase, thereby increasing bladder capacity. It doesn't necessarily suppress the amplitude of the bladder contraction during the voiding stage. The efficacy is better than placebo, but pretty similar to the anticholinergic medications, but they are usually better tolerated. There's some guidelines that support using in combination with the anticholinergic drugs. The side effects they're pretty well tolerated. Some patients may complain of headaches and GI disturbance, reports of elevated blood pressure, and atrial fibrillation. The biggest problem is the cost of these medications. Okay, here is a list of all the medications and some features about each one. For your reference, the third category of medications for urge incontinence are the hormone replacement therapies. Those are the topical vaginal estrogens. They may relieve symptoms of urge incontinence, and I would recommend trying these in either the ring form, which are very expensive, the creams, or tablets. Do not use oral estrogen therapies for this because it can worsen symptoms. There's updated guidelines from the American Urologic Association talking about the pharmacologic management. And basically, it's similar to what I was recommending. You start with behavioral therapies and adding on pharmacologic management until treatment goals are met. And this agency did recommend you can try a combination of anticholinergic and beta 3 agonist receptors. The If all of that fails, this is where you would need one of your specialist colleagues for treatment of urge incontinence. They will look at different options for neural modulation, and the intradetrusor botulism toxin injections have been recommended as a standard third line therapy for overactive bladder. The other ones are a little bit more invasive as sacral nerve stimulation. That is an implanted electrode with an external stimulator. And then the posterior tibial nerve stimulations, those are less invasive, but it does take about 12 office visits for the patient to go to. Again, sake of time, here are your agencies again that recommend very similar approaches that I had just gone over. You can take a look at this for your own reference. Shifting gears to stress incontinence, really the mainstay is topical estrogen and pelvic floor muscle training. Those are the Kegel exercises. There's no magic number. Many physical therapists recommend something like performing 3 sets of 15 contractions and hold them. That is important too, to hold the contraction for about 10 seconds. Sometimes patients need biofeedback. Sometimes patients use weights that they can buy online, but the data supporting these as adding on to good patient education is really lacking. So really focus on educating the patient on pelvic floor muscle training or sending them to specially trained physical therapists for this. Okay, then if that fails, this is where you need your surgical colleagues for either surgery, the midurethral slings, injection of bulking agents, and pessaries. I would really emphasize thinking about pessaries for those women that have stress incontinence. They're intravaginal support devices that can really improve their quality of life. Again, principles of treatment, they're all very similar in their guidelines in terms of the approach and then their surgical and interventional approaches. Treatment for overflow incontinence, this is less common, but if somebody has urine retention from an overflow incontinence and you think it is a neurogenic bladder, there's really no medications to treat this, but what you have to do is do a good medication reconciliation. So you want to look at their medication list, both prescription and over the counter, eliminate anything that's anticholinergic and monitor them for improvement in their neurogenic bladder. Treat constipation. That is also important to make sure that they do not have a rectal impaction. If there's urethral obstruction found, and this is more common in men, but women also can develop this. The mainstay is going to be the alpha antagonist drugs. If somebody needs to have a catheter, the choices are either intermittent catheterization or indwelling catheterization. If possible, it is recommended to educate the patient on an intermittent catheterization schedule, as that decreases the risk of infection and urethral strictures. What are the drugs for prostatic obstruction? They're all alpha receptor antagonists. These are the old-fashioned ones. The newer ones are the alpha 1A receptor antagonists, tamsulosin, alfuzosin, very well tolerated for the most part, similar in efficacy, the less side effects of hypotension and dizziness. And don't forget about the 5-alpha reductase inhibitors mentioned here. This is not for necessarily acute urine retention, but for longer term therapy. Okay. And again, I mentioned earlier, treatment for all patients are these lifestyle changes: weight loss, adjust nighttime fluids, manage lower extremity edema, avoid the caffeine, simple thing of providing pain relief, and don't forget about the safety measures to make them safe.
So let's return to the case of Mrs. Henderson. So based on the history, the physical, and the testing, you've diagnosed her with urge incontinence. So how would you treat her? So based on what Dr. Callahan just mentioned, you would recommend bladder training instructions. You might want to adjust her medications, including her diuretic and amlodipine to minimize lower extremity edema, and also limit NSAID use, which can contribute to fluid retention. Of course, you want to make lifestyle changes, reminding her to limit her caffeine, her fluid intake in the evenings, use compression stockings, and of course, weight loss. And as you noticed that she had some knee arthritis and some pain, it may be helpful to encourage her to use her assistive device for ambulation. And finally, if any of these above things have failed, then you would consider medication. Now, when do you refer? So, of course, that you would refer to our specialists if you're unsure about the diagnosis, especially if you think you need urodynamics, or if your initial treatment is unsuccessful, or if intervention is needed, such as need for a catheter, surgery, or pessary, or if there are any red flags that are found. So recurrent UTIs, prolapse, retention, hematuria for cystoscopy. That is when you would refer. Here's a summary slide of everything that we just talked about in one slide. So it's really important to focus on the physiology of micturition. Of course, remembering the parasympathetic and the sympathetic innervation of both the bladder and the sphincter. It's also important to remember the 4 different causes of urinary incontinence, the most common being overactive bladder or detrusor instability. Main treatments here are the anticholinergics and the beta-3 agonists. Second most common is stress. And here the mainstay treatments are the pelvic floor muscle treatments, aka Kegels. If there is a bladder outlet obstruction, here, the main treatment here is alpha blockers. And then finally, if there's an atonic bladder, other than removing anticholinergic medication, often your only treatment is the catheter. So it is really important to remember to ask your patients the question if they have incontinence, as most symptoms can be evaluated by you in the office, and remember to use non-pharmacologic treatments first. And here are the final take-home points. It's important, again, to routinely ask your patients about incontinence. We know that the diagnosis is made by history, physical, and PVR. Always remember to review your patient's medications for high-risk meds, both prescribed and over-the-counters. It's important to establish treatment goals with the patient and the caregiver. Always remember to treat non-pharmacologically first and refer if your empiric treatments fail or need intervention. Here are 2 questions that we've included for your board review. I'll go over the first one. You have a 73-year-old woman who complains of urinary incontinence. She suddenly has the urge to go and can't get to the bathroom in time. How would you treat her? And here are your 5 choices. Prescribe vaginal estrogen cream. Number 2, pubovaginal sling surgery. 3, offer vaginal pessary. 4, bladder training. Or 5, oxybutynin XL 20 daily. Here's the answer. Number 4, bladder training. So she has urge incontinence or overactive bladder. Non-pharmacologic should be the initial approach, and she should be taught bladder training. Vaginal estrogen creams and or oxybutynin could be added, but oxybutynin should be initiated at a lower dose. And finally, vaginal pessary and sling surgeries are really treatments for stress and incontinence, which is not what she has.
Okay, so I will read out number 2. An 80-year-old man with type 2 diabetes mellitus calls complaining of 3 days of urine incontinence. He's had 1 week of seasonal allergy symptoms and started taking over-the-counter allergy medications. What would you do first? Number 1, prescribe oxybutynin XL 5 milligrams daily, prescribe trimethoprim sulfamethoxazole double strength by mouth daily, twice, prescribe tamsulosin 0.4 milligrams by mouth daily, check the urinalysis and culture. And then number 5 is measure a post-void residual. And the answer is number 5. Want to measure post-void residual. Again, this is a case of acute incontinence, and you have to evaluate this thoroughly before you treat it. So he's developed acute urinary retention and hence an overflow incontinence. The over-the-counter allergy medication probably contains pseudoephedrine. It's an alpha adrenergic medication that can affect the urethral sphincter. And the other answers are yes, it is appropriate to check UA and culture, especially if a PVR is found to be elevated. He is at risk of developing a urinary tract infection from that. Oxybutynin is for overactive bladder. Tamsulosin is for BPH, but should be used only after the over-the-counter medication is stopped. And the antibiotic can be used if an infection is found. Okay, so thank you very much. You have just listened to Dr. Callahan and Dr. Chang speak on urinary incontinence.